I have no further questions. Senator Kaine, did you have anything you wanted to add?
I would ask one additional question to Mr. Wright, if I could. In your written and oral testimony, you note there are, quote, rampant disparities in the transplant system, particularly for Black Americans, as well as other inequities based on ethnicity, income, and insurance status. There was a story in the Washington Post in September that outlined bias in the transplant system that I'd like to be introduced into the record without objection.
Without objection.
And that story documented bias in stories of organs intended for lower income patients being declined and later transplanted into patients at a more affluent hospital. Very concerned about this, and I'm worried that minority communities, people with disabilities, others who are underserved, who already face an uphill battle in accessing care, aren't getting equal access to transplant. So talk a little bit about the types of disparities that exist and how might we address them.
Thank you for the question, Senator. Obviously, there are inequities throughout our healthcare system, and the organ transplant and procurement system rests on top of that, and in some cases, exacerbates them. Issues of socioeconomic status, including your insurance coverage status, issues of poverty or low income, those obviously have a real impact. Again, even the ability to get on the list because of your status. It makes sense for some cases that you need to have if you need to get a transplant, you want to have adherence, but adherence coverage matters, financial barriers matter to that. There's also, but even if you hold for that, there's still racial and other disparities. And so that suggests implicit bias or other things, both in the healthcare system that feeds into the lists in the transplant system and in the system themselves. There was issues about even the criteria and race-based things in the criteria with regard to that. And then I would also just say that there's just a question of transparency and of leadership and of accountability. The work of when there is abuses, like in that Washington Post article and in other media reports, the communities that are hit the hardest by those abuses are typically low-income communities of color, et cetera. When you have investigations of and whistleblowers talking, they talk about how the direction is to target Spanish-speaking or non-English-speaking communities, for example, communities where they can maybe get away with it more. And so I think that there's a need to crack down on whether it's OPOs or others that are failing. And if you do that, you will have a big impact on equity. And then on the positive side, leadership matters. When the OPO in San Francisco had one of the first African-American CEOs of an OPO, they were able to partner with the community and have dramatic increases in organ donation and transplantation for both African-American, Hispanic, and Asian populations by 50, 70, 90% increases. So leadership matters, accountability matters, and that's my answer.
Senator, could I take 2 more minutes and just tell a story? It's just really a story for all of us. Some people will get nervous about the word equity, but I learned a really good equity lesson at the beginning of COVID when the vaccine was first developed. You'll remember that in the fall of 2021, with a limited supply of vaccine, we decided we had enough to vaccinate people over age 65. And so that was kind of aside from healthcare workers, the over 65 cohort was the first cohort available. Talk about a rule that is pure equality. You can get it if you're over age 65. But what I noticed in my neighborhood is because it was still short in supply, there were people who were over age 65 who could spend time on their computer researching which CVS had it and which Walgreens had it, and then they could drive to that one to get it. And there were a whole lot of people who either didn't have a car or they didn't have a whole lot of free time to do that research who couldn't drive to get it. And so what we found a few months into this was a rule that was complete equality. You can get it if you're over age 65. The actual result was that the most affected communities, those that were getting COVID at the highest rates and those who were suffering the most serious consequences to COVID, were usually much less successful in actually accessing the vaccine than others. And so we had a rule that was equal, but because we didn't also build in a little bit of an equity component, it wasn't that effective. I think effectiveness should be the key. And we had a rule that was equal but not equitable, and hence it wasn't effective. We ended up, making some different decisions, uniformly in a bipartisan way, Congress and the administration. Take vaccines to targeted populations that are most at risk, whether they're, frontline workers or senior centers because of people's age and health condition, they could be most at risk. Go into public housing communities where people might not have transportation. And so equity is not something that should make everybody nervous. We ought to be asking questions about effectiveness, and sometimes rules that are purely equal end up with results that actually aren't that effective. And so I appreciate, Mr. Wright, you talking about ways we could make this system or healthcare generally more effective by focusing a little bit on the equity side. Thank you. And I'm finished and yield back.